Places, gentlemen. This is a subject near and dear to my heart. We're going to do dysrhythmias. This is what I devote my life to. This is all I do all day, every day. So we're going to try and make this simple, but the simple fact of the matter is there is no simple dysrhythmias, okay? I've never found an EKG book that isn't at least a little bit difficult for someone who's never seen an EKG to get into. And so you got to start somewhere, and you might as well start with an understanding of what the heck an EKG is, okay? An EKG is a tracing of all of the electricity of the heart, all summed up, all at once, okay? With a standard body surface EKG, there's no way to separate out one chamber from another chamber, to separate one side from another side. All you can do is view it in different angles, okay? So I can look at him right here, and he can look like this, and I can turn over here and look at him like this, and he looks different in those two appearances, okay? But nonetheless, he is what he is. I can't find some way to look and only see an arm, okay? There's just no way to do it. Same thing is true here. So the signals are going to get mixed up all the time. Fortunately for us, the heart operates in an orderly sequence, which by its very definition separates a lot of these signals for us, okay? So we have the P wave, which represents what?
P wave is the
atrial depolarization. The QRS represents the good. And within the QRS, what silently happens? Atrial repolarization, which is such a weak and pathetic signal that you cannot see it at all. And then there is the T wave, which is the ventricular repolarization. Good. So this is caused by the action potentials of each individual cell adding together all at once. Billions of cells all doing this at different points in time. Okay? Phase 0 of the action potential is caused by a massive inrush of sodium, which is then balanced by a potassium and calcium mix over here, before ultimately potassium ends up driving this back down to a reset, and we repeat this entire process all over again. So the heart is comprised of a sinoatrial node. This is the dominant source of pacemaking in the heart. This is what drives your rhythm. It is what is referred to as a coupled calcium clock. Couple of special proteins cycle calcium back and forth, and as they do that, it's like the swinging pendulum on a grandfather clock. Tick, tock, fire a beat. Tick, tock, fire a beat. Okay, same idea. This is exceptionally responsive to both vagal and chemical stimulation. So when I say vagal, I mean direct nervous stimulation from the vagus nerve. It literally stops right over the sinoatrial node and squirts acetylcholine on the sinoatrial node to slow it down. And norepinephrine and epinephrine circulating in your blood volume chemically act on this same area to accelerate that clock, okay? That signal is then carried across the atria. It spreads from the right atrium to the left atrium. There are 3 specific conduction paths for the right atrium to get to the left atrium. They are not just inherently tied together as one blob. You can actually separate the atria from each other if you want to. And in the right atrium, that signal travels down into a region called the triangle of Koch, where it then picks up the AV node. The AV node is a time delay fuse, okay? It receives the signal the same way a fuse receives a match strike. And it burns for somewhere between 120 and 200 milliseconds in normal physiology before it then fires off a signal down the His-Purkinje network. Now, this is a 3-lane highway, okay? You have the right bundle, the left anterior fascicle, and the left posterior fascicle. Those latter 2 have a common on-ramp referred to as the left bundle. Okay, so it's the common His-Purkinje system. It throws off the right bundle first. Now you're left with just the left bundle over here. The left bundle then splits into the left anterior and left posterior fascicles. Okay. Now, the sinoatrial node is what we refer to as automatic. You can literally cut it out of the heart. As long as you supply it with the nutrients it needs to stay alive, it will fire all on its own. The atrioventricular node is also automatic, but nature has carefully designed the atrioventricular node to be automatic at a rate that is slower than the sinoatrial node most of the time, okay? So think of the AV node as your emergency backup generator. If the power goes out upstairs, the emergency backup generator should kick in and give you a heart rate of about 40 to 45 beats a minute. The range for the sinus node should generally be between 50 and 100 beats per minute. The range for the junction should generally be between 40 and 60 beats per minute. The remainder of the tissues beyond the AV node are not considered automatic tissues. They will fire in times of distress, but not reliably, which is why if a patient has lost both their sinoatrial node and their atrioventricular node, or just their atrioventricular node, we generally need to give them a pacemaker, even if they're still making their own heart rhythm, because it is unreliable. These tissues are not meant to design their own heart rhythm. Accessory pathways are a birth defect, okay? When you are making a heart, there is a seminal moment where the tissue has to pick sides. It's either go that way and be atrium or go that way and be ventricle. But every once in a while you get some cells that are dee-dee-dee, and they're not paying attention when the muster call goes out, and they're just sitting there twiddling their thumbs, neither atrial nor ventricular be they, and they end up bridging those two tissues. The only thing that should ever bridge those tissues is the AV node. These pathways exist on the outside of the heart or in the septum of the heart, and they can create a short circuit where electricity goes down the normal pathway, up the abnormal pathway, or the reverse, down the abnormal pathway, up the normal pathway, okay? The real danger of an accessory pathway is if you get atrial fibrillation while you have one. Some of these accessory pathways are what we call sodium-dependent or non-decremental, which means that they can conduct electricity at blazingly fast speeds. When you have atrial fibrillation, the top chamber is doing between 450 and 600 beats per minute. And if that pathway lets down more than about 200 or 250 is usually the cutoff we use to call it dangerous. If it lets down more than about 250 of those impulses a minute, it can scramble the ventricle and cause the patient to go into VFib. Okay? These pathways must be eliminated by someone like me if they're able to conduct the impulses that fast. Otherwise, the patient could suffer sudden cardiac death. Okay, the autonomic nervous system I've just talked to you about, that's the sympathetic nervous system, chemicals through the bloodstream. The vagal system or the parasympathetic system directly squirts onto the sinoatrial node and the blood vessels, and then there is a chemical component that also affects the AV node. We have talked about these baroreceptors in the neck. If I go up to any one of you and I mash firmly on the point of your carotid pulse just underneath your jaw in the neck, your body will perceive that as a massive spike in blood pressure. I told you the body's dumb. Okay? They're stretch receptors. Anything that causes them to be irritated, the body will perceive as a massive increase in blood pressure, and what it will do is try to relax you with a massive squirt of acetylcholine onto the heart. Okay? So we can use this to our advantage. If we have a patient who is in supraventricular tachycardia, we can mash on the neck, we can trigger that vagal reaction, we can make the AV node slow down. We can't stop the accessory pathway, but we can stop the AV node, right? And you got to have both parts to complete the loop. Doesn't matter which part we break. Break the AV node, fine. That's also what adenosine does via the A2 receptor. Adenosine works directly on the AV node and blocks that impulse from conducting through. Same thing, terminates SVT, just like that. There are lots of vagal maneuvers. You can bear down, strain like you're having stool. You can get them to blow through something they can't blow through. So like a small drinking straw, blow as hard as you can. Blow real hard against that. That creates that same abdominal pressure. You can mash on the carotid. You can slam their face down into ice cold water. That's called diver's reflex. You can mash into their eyeballs. Okay, that's a vagal maneuver. I don't recommend that. There may be lawsuits involved. But if you mash into some combatant's eyes someday and you notice he passes out right afterward, you know what happened. You serve at a vasovagal episode. I'll be seeing you. And then you shoot him. Okay. Causes of cardiac dysrhythmia are many. Okay. Anything that causes an imbalance in the heart's electrical flow of these sodium, potassium, calcium ions can cause a cardiac dysrhythmia. Here's a huge list of things you don't have to memorize that can cause it. Okay? The leads of an EKG each look at the heart in one specific direction. Just like I can look at you from the front, from the left side, from the right side, they do the exact same thing. Lead 1 is looking at right to left electrical activity. Okay? There are only 3 active electrodes of the 4 that you connect to the patient. The right leg, in almost all EKG systems, is ground neutral. Its sole purpose is to reject noise off the EKG. The left leg, left arm, right arm are the 3 active leads that form this so-called triangle here, okay? So, 1 looks at right arm to left arm, 2 looks at right arm to left leg, and 3 looks at left arm to left leg. So, when you're looking at an EKG, if you get a bunch of artifact on it, you can figure out which one of the patches is bad by which 2 of these 3 have noise on it. So, if lead 1 and lead 2 both have noise on it, then you can safely assume that it's the right arm, because that's the only common electrode for lead 1 and lead 2. Does that make sense? Okay, it's a fun little trick. So that wasn't good enough. They said, well, okay, that sucks, because lead 2 and lead 3 are kind of at these weird angles, and they're sort of hard to mentally get a grasp on, right? So what do? They say, okay, well, let's make up some new leads. And it turns out that if you sort of tinker with the electrical components, you can create vectors that are 90 degrees to each of these vectors. Well, what does that do? That does something really, really useful for us. We already had a vector that went right to left, left to right. That's lead 1, right? Well, now what we've done is we've invented a vector that goes top to bottom, bottom to top, directly vertical. Woohoo! And that is AVF. Hi, buddy. AVF is your friend, okay? That tells you whether electrical signals are going down or going up, and it is the key signal of the inferior group. Remember we talked about the territories earlier? AVF is the most inferior of the inferior groups. Okay. Then they said, well, that's not good enough. I want to know whether something's more on the right side or the left side, but I also want to know whether it's kind of on the right side of the heart itself, the right heart or the left heart. So they invented these precordial leads. These are what are referred to as unipolar leads. And they are designed so that V1 can help you figure out whether a signal is coming from the septum or right ventricle, or whether it is coming from the left-hand side. And V6, way out here, shows you the far lateral aspect of the heart, which can't be seen by any other means. Okay. So then there are some special lead placements. This is for to check for right-sided heart attacks. This is to check for posterior heart attacks. The way that you configure these are right there. The key to this one is for the modified lead placement, the key here is, and I think it shows it, yeah, it sure does. V1 and V2 are placed in order, in the normal order, V1, V2, and then it reverses the order, 3, 4, 5, 6 as it goes to the right, which just seems very, very counterintuitive. All right. So ECG axis is relatively easy to determine whether it is normal, okay? It's easy to determine whether it's normal. Are you ready? Write this down. If lead 1 and lead 2 are both positive, it's normal. The end. You are allowed to have a small amount of left axis deviation, up to negative 30 degrees, but the lead 1, lead 2 criteria I just gave you takes that into account, okay? So if lead 1 and lead 2 are normal, you're done. Call it a normal axis and move on, okay? That means that the axis is somewhere between negative 30 and plus 90 degrees. Okay? When I say positive, what I mean is that both of those two are more positive than negative. You can have some negative component just as long as you have more positive. Everybody with me on that? Clear as mud? Perfect. Now, to figure out the axis is also fairly easy, at least to get it into the quadrant. Okay? All you need is two leads, lead 1 and lead AVF, okay? When a signal is going in the direction of a vector, it's positive. When it's going in the opposite direction of a vector, it is negative. I already told you that lead 1 goes from the right shoulder to the left shoulder, so that's a right to left, okay? The electrical signal of the heart is supposed to go right to left, okay? It starts in the high right atrium and it washes over into the lateral edge of the left ventricle. So, if you have a positive lead 1, you must be on the on the left-hand side of the circle, okay? If you have a negative lead 1, you're going in the opposite direction and you are over here. If lead 1 is negative, you have right axis deviation, okay? If lead 1 is negative, you have right axis deviation. AVF should be positive if you are in the bottom half, and AVF should be negative if you are in the top half. So to figure out which quadrant you're in, all you have to do is look at 1 and AVF. So let's practice. Lead 1 is negative, AVF is negative. Okay, lead 1 is negative, so I know I'm on this half. AVF is negative, so I know I'm on the top half. It must be in this quadrant. Okay? No exceptions. That's the answer. Okay? Lead 1 is positive, lead AVF is positive. Okay? Lead 1 is positive. I know I'm over here. AVF is positive. I know I'm in the bottom half. The only thing that's both on this side and the bottom half is this quadrant right here. We good? Don't worry, it makes more sense when you review it on video. All right, we're going to keep moving. EKG paper is universal across the United States, but not across the world. There are different standards in certain countries for both the speed and the scale. In the US, these are the values right here. Every small box is 0.04 seconds or 40 milliseconds. Every big box is 0.2 seconds or 200 milliseconds, okay? The vertical axis represents the scale in millivolts. There are generally 10 millimeters for every millivolt measured by the EKG. I do not believe this is testable material for you, so we're going to keep on moving. ECG intervals, there are a couple that are important. PR interval measures the amount of time it takes to get from the atrium through the time-delayed fuse down into the ventricle. What it generally is considered to reflect is the AV nodal delay plus the His-Purkinje delay. The His-Purkinje delay in a normal human being should be 3 to 5 times shorter than the AV nodal delay. Okay? Okay. The QRS duration reflects how long it takes to get all of the myocardium to fire off. All right? The sicker you are and the more damage you have to your wiring, the wider that will be. Okay? Now, by the same token, if you have severe electrolyte abnormalities, the same thing will occur. Okay? It'll be slow conduction. What is the electrolyte abnormality that causes the most widening of the QRS? And what specifically about potassium? Hyperkalemia. Hyperkalemia will take the QRS and stretch it out until it becomes what we refer to as sinusoidal. Okay, it just kind of, all right? And how do we treat hyperkalemia? That's one option. That's the one I wanted to hear, is calcium. That immediately stabilizes the cell membranes of the heart against the effects of potassium. Doesn't fix the potassium problem, just stabilizes the cell membranes against it. Okay. Calcium, number 1. What else? Sodium bicarb, that's one option. That buffers it. That's a trick, right? You're trying to move the potassium into a place where it's less dangerous. What else? Sorry? Dialysis, fine. Perfect answer, just not a very quick answer, but definitely useful. What else? Glucose, that's right. Glucose plus insulin is actually the key there. So you give them an amp of D50 and 10 units of insulin, bam, back to back. Hit them right then and there, and you can drive that potassium into a less dangerous location. Exactly. Other things that you can do, epinephrine or inhaled albuterol. Epinephrine does this to an extent. Inhaled albuterol at very large doses. I mean, like, go ahead and just completely fill up the neb with albuterol and just just have them suck it down at full speed. That can do the same thing. The other thing that I haven't heard is K-exolate. That's like a styrofoam product. It's polystyrene that you put into their gut. It's got a charge on it, a negative charge, that draws the potassium out of the gut, and then they poop it out. Okay, again, slow fix. All right, so your immediate fixes: calcium, bicarb, insulin plus glucose, that combination, inhaled albuterol. And then you worry about your longer solutions. Yes?
Does it matter if it's calcium carbonate or calcium glutamate?
Does not. As long as it produces free ions. All the code syringes, as far as I know, are calcium chloride, unless they've changed it. But don't quote me on that. Okay, how to interpret an EKG. The real answer is it doesn't matter how you interpret an EKG. There's no right answer, okay? This is not like, someone figured this out as the best way, okay? The answer is that you have to have a system, okay? It's like, how do you shoot a gun? I don't know. I don't think there's a specific best way to become a marksman, but you have to have a methodical process to get to the point where you're ready to pull the trigger, right? People have different routines for how they get there. As long as it is a consistent process, though, you're going to achieve results, right? Same thing with room clearing, okay? Not all the squads are going to teach room clearing in the exact same fashion, right? But they are all going to have a methodical way to do it so that every single member of that squad knows exactly what every other member is going to do. Same idea here. You have to have a system to look at the EKG so that you don't miss critical points. Because it's not until after you've read 10 or 50,000 of these things that you can just kind of hold it up and go like, yeah, it's this, and throw it away, okay? I mean, it really does take that long. And, at this point in my career, I've probably read 250 or 300,000 of these things. But, it's a real long time. And, even knowing that I wanted to do this forever and ever, those first 10,000 are rough. Okay? I mean, you really got to pay attention. So, they suggest considering the rate, the rhythm, the axis, the morphology, the intervals, and then go looking for ischemic stuff, like ST segments. Okay? That's not a bad way to do it. That's fine. So, here's how you do rate. It's real simple. The rate should be between 3 and 5 big boxes. The rate should be between 3 and 5 big boxes. The rate should be between 3 and 5 big boxes. If the rate is less than 3 big boxes, it's too fast. If the rate is more than 5 big boxes, it's too slow. Cool? Okay. Rhythm. What is the source of the rhythm? What you're looking for here is P waves. If the P waves have a fixed relationship to the QRS, the P waves are almost always the source of the QRS, okay? Now, when I say a fixed relationship, all I mean is a relationship in which the P waves have a very regular pattern to the QRS. It doesn't necessarily have to be in the exact same place every time, as we're going to talk about in a moment with type 1 heart block, okay? Axis, we just talked about axis. Again, go back, review the material again, if you need to look at axis. Morphology, is the QRS narrow or wide? Ignore this double peak thing, that's ridiculous. It's narrow or wide. What they're talking about with double peak, they're trying to teach you how to read a right bundle branch block. That's if it's got a double peak in V1. Intervals. The PR interval should be between 3 and 5 big boxes, 3 and 5 small boxes. I'm trying to make this easy for you. You only have to remember one thing, 3 to 5, okay? 3 to 5 big boxes for the QRS, 3 to 5 small boxes for the PR interval. If it's more than 3 to 5 small boxes, more than 5 small boxes, you have type 1 AV block, PR prolongation, okay? The QT interval is from the start of the QRS to the end of the T wave. Here's the easy way to simplify that. If the T wave ends more than halfway between these two QRSs, it's too daggone long. You're allowed to go up to halfway through. If it's significantly more than halfway through, it's too long for the QT interval. We good? Yes? Does this make sense? Am I explaining this clearly? Okay. ST segments we already talked about. They can be elevated, they can be depressed. Never call a change that's less than a millimeter. Just call it I mean, I see it, but, right? All the significant stuff, all the clinically relevant stuff is going to be at least 1 millimeter. Okay, very good. Rhythms originating in the sinoatrial node. Normal sinus rhythm. You can't see the large box versus small box divisions on this, so this is going to make it very tough to talk about it on these slides. Normal sinus rhythm, sinus bradycardia, and sinus tachycardia are all just 3 variants of sinus rhythm, okay? The only difference is this one is more than 5 large boxes, this one is less than 3 large boxes, and this one is somewhere in between them. Clear? Yep. Okay. Sinus pause, that means you were going along and you had nice normal P waves occurring at some regular interval, and then the P waves just stopped. Boop, they're just gone. That's a sinus pause. Premature atrial contractions mean that you were going along in sinus, and then you have a little squiggle, boop, somewhere either in or right after the T wave, usually pretty pointy. And then you see another narrow, here's the key, narrow QRS after it. That's a premature atrial contraction that made it through the wiring and managed to trigger off another beating of the lower chamber. Okay? This is very different from a premature ventricular contraction. What's the difference between the two? How do you tell the difference on an EKG?
Ventricular contraction is going to be wide.
That's right. A PVC is a wide beat. That's more than 3 little boxes. If the the QRS is wider than 3 little boxes. A QRS should be less than 3 little boxes. Okay, less than 120 milliseconds. Okay, sinus dysrhythmia is something most of you in this room will have because you're in excellent physical condition and you're relatively young. Okay, sinus dysrhythmia or sinus arrhythmia is just fluctuation in the heart rate as you breathe in and breathe out. What it reflects is how good your vagal tone is. The more you work out, the more fit you are, and the younger you are, the more your body is dominated by a vagal state. You want to be in a vagal state whenever possible. Okay? Vagal states are great. You live a long time in a vagal state. If you're on adrenaline 24/7, you're going to die of a coronary in your 50s, right? Okay? So when you see this, this is actually a healthy marker. You're like, all right, good for you. All right. Supraventricular tachycardia is a narrow, complex rhythm in which you cannot see the P waves. This is not the accurate definition. Okay? This is not the precise definition that someone who does what I do wants for supraventricular tachycardia, but it will get you the right answers on your tests, your boards, and in the rig. Okay? Very fast rhythm, narrow complex, can't see any P waves. Okay? Give that patient adenosine, see what happens. Okay? Half the time it'll go away. Please do me a favor. Run strips while you do it, okay? There's nothing worse than the rhythm terminated to adenosine and there are no strips. Thank you. Now I can't see either the rhythm or how it terminated. I've learned nothing that I can use to help that patient at subsequent procedures, okay? Try to get a 12 lead of them when they're going fast. And in the hospital, I get 12 lead rhythm strips. None of your rigs, I don't think, can run continuous 12 lead. So at least get a continuous 1 lead rhythm strip of the thing terminating. Okay? Great. Moving on. Rhythms that originate in the atria. This one right here that looks like it's got shark fins all the time. What is that rhythm called? Atrial flutter. Okay? As soon as you see that, send them to me. I can fix this with a 15 to 20 minute procedure. They'll never have it again for the rest of their life. The end. Gone. Okay, we know what causes this. It's a loop rhythm in the right atrium. Rate of complications for the surgery to fix that. I've never hurt someone doing that in almost 1,000 of these. Okay, theoretically, I should tell you the rate of complications is 1%, but the point is, I mean, for people who do this all the time, this is one of the safest procedures we do. Okay, if I had this problem, I would have it fixed by next week. All right. Atrial fibrillation is the opposite of atrial flutter. It's the opposite of every rhythm, actually. What it is static. Okay, atrial fibrillation is static in the top chamber. When I put my special wires up there to do the surgeries that I do on heart rhythms, the definition of AFib is that when I put those wires up there, there is absolutely no pattern to anything. It's just total chaos up there, random electrical activity. All right? Wandering atrial pacemaker. The key to wandering atrial pacemaker, and this is an absolutely horrific example of wandering atrial pacemaker. The definition of that is that the P wave morphology keeps changing. For it to be called wandering atrial pacemaker, or its faster cousin, multifocal atrial tachycardia. They're the same thing. One's just fast, over 100 beats a minute. The other one is at a normal rate. You have to have at least 3 different P waves. So what I advise people is look for one pointed up, one pointed down, and one that's either not pointed at all or that kind of wavies, okay? If you've got those, you've either got wandering atrial pacemaker if it's less than 100 beats a minute, multifocal atrial tachycardia if it's more than 100 beats a minute. Rhythms originating in the AV junction. This is junctional tachycardia. I want to call this one out first because to you, this should be indistinguishable from SVT. I want you guys to call this rhythm SVT every time unless the thing doesn't have an answer choice for SVT and does have an answer choice for junctional tach. Because this is a narrow, fast rhythm where you can't see clear P waves, okay? Accelerated junctional rhythm and junctional rhythm are the same. The only difference, again, is that accelerated junctional rhythm is faster than 60 beats a minute, okay? And premature junctional contractions are a narrow beat with no visible P wave in front of it, okay? Premature junctional contractions. Narrow complex beat, no P wave in front of it. Rhythms originating in the ventricle. These are where we start getting into trouble, okay? The key to this is all of these, okay, with some exceptions that you guys will never need to know about, are wide, okay? If the patient's regular EKG is narrow and now they are wide, you are probably in the domain of rhythms originating in the ventricles, okay? So if you go to the emergency department, you pull 1,000 EKGs of wide rhythms. That means the QRS is wider than 3 beats in patients who ordinarily have narrow rhythms. Or if you go to the ER and you pull 1,000 EKGs of patients who are greater than 100 beats a minute and have a wide QRS, you have an 80% chance right off the bat that you're dealing with one of these ventricular rhythms and probably a dangerous one, okay? So if you don't know if it's real fast and it's real wide and you just don't know and the patient is hemodynamically unstable, what are you going to do? You got 2 options. Number 1, you can give them adenosine. Ventricular tachycardia does not care about adenosine, okay? It'll just laugh at you, all right? That's option 1, because if it comes from the above, up in the chambers, the adenosine will make it stop. Option number 2 is just cardiovert it. Nobody ever died of getting a shock that you appropriately delivered, okay? They may be mad at you, they may curse, it may hurt, but they won't die of it. They will die of untreated ventricular tachycardia and a blood pressure of 50, all right? PVCs. PVCs is a twitch. It's like an eyelid twitch. It's just an imbalance in the muscle, okay? And you can trigger it the same way you can trigger eyelid twitches. Not enough sleep, too much caffeine, taking crystal meth. Oh, wait. So these PVCs are not a problem unless there are a ton of them. If there's an absolute ton of them, like more than 25% of their heartbeats are PVCs, in the very long term, over the course of months to years, it can cause heart failure. Those people I need to ablate. I need to get rid of their PVCs. Couplet just means 2 PVCs in a row. And again, I hate this example because this one, while it is just barely wider than 3 small boxes, if you showed me that right off the bat, I mean, the only thing that would tell me that that's a PVC is the fact that this points up and that one points straight down, and that's not something the heart does, okay? They're usually going to look more like this, all right? Now, once again, we go through a whole bunch of things that are the exact same thing. The only difference between them is how fast they are. Idioventricular rhythm is a ventricular rhythm that is less than 60 beats a minute. An accelerated idioventricular rhythm is a rhythm that is wide, complex, and 60 to 100 beats a minute. And ventricular tachycardia is a wide, complex rhythm that is more than 100 beats a minute. Okay, that's the only difference. All right. Torsades is a very special rhythm. You need to recognize this on site. Why is torsades important?
Medication use different than everything else?
Can be, yep. So how is it different?
It's
Magnesium can often terminate torsades. If you give them a big slug of mag, like 2 grams of mag, just bam, you can often terminate this rhythm. There's another reason why, and that's because a lot of times torsades is caused by long QT. Okay, so what you don't want to do is give that patient a bunch of Zofran, a bunch of amiodarone, and drag that QT out even more. When you see torsades, they are going to go into VFib if they don't self-terminate. The nice thing about torsades is that generally speaking, most episodes of torsades last a few seconds and burn themselves out. Okay, but if you see that, treat it like VFib. Shock it if you don't happen to have magnesium sitting right there. And even if you do have magnesium sitting right there, their blood pressure is going to crash pretty quick. As soon as they pass out, stop looking for your magnesium and just shock them, okay? All right. Coarse VFib, fine VFib, and asystole. If you ever see a patient in asystole, this is not an ACLS, this is my advice to you from having done electrical rhythms for 12 to 14 hours a day for 8 years. If you ever see a patient in asystole at a code, you shock them. You give them 360 joules to the chest and see what happens. Because if they're really in asystole, no harm. If they're in fine VFib, you may cardiovert them back to sinus and bring a dead man back to life. And the difference is how high you have the gain set on the EKG, right? So this fine VFib, if you gain that down from 3x to 1x, it's going to look just like this on your monitor. And a lot of you are going to be carrying LifePak 12s and LifePak 20s. And the screens on those things aren't that high res in the first place. So like I said, if you show up and you've got an unconscious patient who is in asystole, start by shocking them, okay? No harm, okay? George can tell you not to listen to me later, but I'm telling you, I have seen many occasions in which this is just under-recognized VFib. All right? All right. AV block, this is always the hardest part. This is the one that people flunk the most on the test. It is the most difficult to recognize. First degree AV block is stupid. It shouldn't even be called an AV block because nothing is blocked. It's still making it through, okay? It should be called AV delay, not AV block. What it means is that from the start of the P wave to the start of the QRS is more than how many small boxes? More than 5 small boxes. Okay, done. Cross it off the list. Third degree heart block is the next one you should learn because it's the easiest one to separate. And then if it's not this and it's not this, then you just have to figure this out, okay? So third degree heart block means you can take a pair of calipers or a piece of paper that you make some marks on, and you can make marks for the P waves, and the P waves will keep those marks. And you can make some marks for the QRS, and the QRS will keep its marks, but the P wave and the QRS have nothing to do with each other. They are literally doing their own thing, okay? The P waves are doing what they do, the QRS is doing what it do, and they are not talking to each other, okay? We good on that? Okay. Now, all we have to do is get through the second degree AV blocks. This means that not every P wave is getting through. So, to have one of these blocks as a fundamental condition, you should have regular P waves. If you don't start with regular P waves, you can't necessarily call it heart block, okay? So the P waves should be marching through in both cases. P wave, 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 P wave. They should be occurring on time. The P waves aren't the problem here, right? It's the lower chamber that's having the problem. So there's no reason why the P waves should be getting all weird. They should be pretty close to right on point. Okay? Same thing here. P wave, P wave, P wave, P wave, P wave. You got to start with regular P waves before you call a heart block. Okay? Now, type 1 likes to run. So the P wave runs away from the QRS. It starts out kind of short and gets longer and longer and longer. And here's the pro tip. Okay? This is what they don't teach you, but this is how you don't miss this. If the PR of the last conducted beat is longer than the PR of the return beat, the next one that's conducted, it's type 1. Okay? Don't spend as much time worrying about the longer. Worry about, is the PR of the very last beat before the dropped P wave longer than the PR of the return beat? If it is, that's how the pros diagnose Wenckebach. The longer thing is not actually required for it to be Wenckebach. It's actually a side effect of the thing that I just told you, okay? If anybody ever wants to know how, I'll tell you it's fascinating. It's not worth this lecture. Okay, in this one, type 2, sticks like glue, okay? No matter where you measure it, every QRS that does conduct is going to have a P wave at the exact same spot in front of it, okay? You may conduct 1 out of 4. You may conduct 1 out of 2. You may only drop 1 beat out of 10. But for every QRS that conducts, that P wave is going to be in the exact same spot relative to the QRS. Clear? Type 1 likes to run. Type 2, it sticks like glue. Fantastic. I have no idea what any of that is. Defibrillation is always a good idea if you have a fast rhythm, you have no idea what it is, and your patient is unstable. I will say that again. Defibrillation is always a good idea if you have an extremely fast rhythm, an extremely unstable patient, and you don't know what's going on. Okay? 360 joules will cure all that ails you. Now, when I came to Cox, I was the only person that wanted to give high energy shocks. Okay? I know a few things that are not common knowledge. The reason 200 joules was set as the defibrillation energy is because 200 joules was all the original biphasic defibrillators could do. It was the max energy for those defibrillators, okay? They go to 360 now across almost all of the vendors, all right? Number 2, I know that you cannot injure a heart with defibrillation unless you create something called electroporation, and none of these defibrillators are powerful enough to create electroporation. And number 3, I know that the pain of a low energy shock is equal to the pain of a high energy shock, whether it be 10 joules or 300 joules, it's going to hurt the patient about the same. And finally, I know that the rate of thermal injury is about the same between 100 joules, 200 joules, and 360 joules. Fortunately, the rest of the world has caught up with us, and they just published 2 papers at the European Society of Cardiology just 2 weeks ago that showed that there is no advantage to doing staged energy shocking, and going directly to 360 causes less injury to patients and achieves better results in less shocks. Okay? My take on it, this is Garner's take. Again, do what your instructors tell you, but Garner's take, and again, I've done this more than once or twice, is if you're going to go for gusto, okay? If you gotta hurt a patient, try not to hurt them more than once, okay? They would much rather get 1 360 joule shock from you than a 100 joule shock, a 200 joule shock, a 250 joule shock, a 300 joule shock, and finally the 360 joule shock that worked, okay? Okay, very good. Defibrillation versus cardioversion is really a matter of semantics. Okay, cardioversion means I'm taking a regular rhythm and I'm restoring it to normal rhythm, and defibrillation means I'm taking a scrambled rhythm and resetting the entire heart. It has to do with some electrophysiologic properties called wavefront extinction versus wavefront collision versus refractoriness, and something called the upper limit of vulnerability. It is all phenomenally boring, and I encourage you to learn nothing about it. The real key is that if the rhythm that you have is regular, what do you need to do on the defibrillator before you zap them? No. What is it that you have to do? What setting on your defibrillator do you have to set if the rhythm they have is regular? Sync. Shock with sync, okay? If they have a regular rhythm, shock on sync. If they have obvious AFib, shock on sync. If they have a rhythm that looks like that, do not shock on sync. Turn off your sync and shock. When you defibrillate, on most defibrillators, the device will automatically turn off sync after it delivers the shock because it assumes your patient may go into VFib next, and it doesn't want you frantically hitting the button wondering why nothing's happening. And why nothing's happening is because the defibrillator can't sync to VFib. Okay? Why do we use sync? Does anybody know? to not capture the T wave. You're very close. We capture the R wave to not capture the T wave. If you shock with a low enough energy, not a high enough energy, a low enough energy on the T wave, you will fibrillate the patient every single time. Okay? Another good reason not to screw around with these low energy shocks. Go for the maximum energy. It has the lowest probability of ever inducing VF. Okay? All right. Very good. Select energy for delivery. See, 125. No, no, no. 360. If you're going to go for gusto. Stable versus unstable. This is stupid. I think you guys know what stable and unstable are at this point, right? Moving on. Bradyarrhythmias. What's the drug of choice for bradyarrhythmias? Atropine. And if atropine doesn't work, what do we use? Yes. And how do we pace? Pads are in the what position? Anterolateral or anteroposterior? Anterolateral. Anytime you want to capture the ventricle, you do it in anterolateral. If you're trying to cardiovert an atrial arrhythmia, you want anteroposterior. For paramedic purposes, you always want anterolateral. Okay? Now, here's the key. Are you guys ready to receive knowledge? Transcutaneous pacing sucks. The capture rate of transcutaneous pacing is only 50%. Okay? However, when you capture with transcutaneous pacing, you also create powerful contractions of the thoracic cavity in the majority of patients, okay? Those contractions countermand the pulsatility that you get out of the capture and impair the blood flow. Only 20% of those you manage to capture will ultimately go on to have a meaningful radial perfusion pressure, okay? So, the rate of transcutaneous pacing saving your patient is poor. Okay? This is not the magic panacea everybody tells you it is. We hear this in the cath lab, the EP lab all the time. People go, well, you could just transcutaneous pace him. Hogwash. Okay? I just reviewed this literature for a lawsuit over in Arkansas the other day. The numbers have not changed over the years. 50% capture, 20% of those will actually generate a useful pulse. Terrible. Try never to put a patient's life in need of transcutaneous pacing. Okay? If you have transcutaneous pacing, do not rely on that as a source of the patient's health. Okay? Get that pulse ox on them, and if you don't see a pulse ox waveform to go along with those beats, you better start CPR. Okay? Sound good? All right. Valuable lesson. One other lesson for you. Life packs require the monitoring electrodes to be attached to the patient. You cannot transcutaneously pace on many models of life pack through the patches alone. This is a very, very common cause of failing in rural hospitals that do not get proper education on this. Bad paramedic training does the same thing, okay? If you plan on transcutaneously pacing that patient, you gotta have those 3 little sticker electrodes on there, or many models of life packs will not allow transcutaneous pacing. You'll keep hitting the button and it'll go unavailable, unavailable, unavailable. And you're talking about unavailable. You don't have surface monitoring, so it won't let you do it. Okay. Atropine, they change the dose all the time as they keep changing the ACLS algorithm. Basically, by the time you get to 1 milligram, you've given them a full dose. Most of the time, if they're kind of stable, you give a 0.5 milligram. If they're really unstable, you just give the whole milligram and say, yeah, I'd rather you be way too fast than not, going at all. Okay, tachyarrhythmias, again, follow your ACLS algorithms for this. And if it's really fast and your patient's really unstable, what do? Shock them. Stop messing around. If you see this rhythm right here, what are you going to do? Shock them. It may be asystole, it may be fine VFib, but you're sure not going to hurt them by shocking them. We actually just proved that in the cath lab, actually, the other day. We had a patient, I walked in on a code, flat line. I said, shock him. They said, what? I said, shock him. Boop, boop. Okay, so this is very difficult to remember. I carry this in an app on my phone. When I show up in a code, I have a little program that keeps track of the timer because you lose sense of time while you're doing it. It tells you when to give your epi and everything. And it's got a little button you can push that'll bring up this list. These are the things that you figure out once the patient has a pulse and once the patient is oxygenated, okay? If you're still coding them, then you go on to the H's and the T's. And you say, how the hell is this happening? That's the H, I think. And the T is, take over for me, would you? Because I don't want to be doing this anymore. All right, high performance CPR. you know, you do it to the Staying Alive song. You need a compression depth of at least 2 inches in order to achieve effective CPR. I somehow think this crowd is not the one that is going to fail to deliver CPR effectively. Your biggest problems will be to allow full recoil and to not try to prove to the room that you are in fact the best in your squad, okay? There is a correct rate for this, all right? It's not a contest, you don't win. And the other thing is, as tough as you guys are, 2 to 3 minutes, everybody is gassed. Get out and get someone else to do it unless you're literally the only person who can. Trade off with people. In a code, always stack them deep. Okay, you need 3 to 4 people rotating on CPR. Every 2 minutes, the person behind needs to force the person ahead to move, because the person doing the CPR will never want to move. Just say, move. 2, 3, 4. Okay, do the count in your head. If you're the CPR guy, just keep counting. When you get to 120, get off the deck and let someone else take over, okay? It's the best way to save the patient. Don't have exhausted responders. All right? Ventilation, they talk about a lot. Ventilation is less and less and less important as they keep developing additional CPR guidelines. It used to be get the ET tube in, get the ET tube in, get the ET tube in. Now it turns out that you got enough oxygen in there to last like 7-8 minutes. The real problem is to get the circulation going. Okay? The real problem with ventilation is the buildup of carbon dioxide. Once you have the circulation set, you got to ventilate them, and for the initial portion you need to hyperventilate them to get off the built-up CO2, but after about 30 to 60 seconds of that, you got to slow down and just do 12 a minute. Again, with the adrenaline pumping in a code situation, you will always do this too fast. How many seconds elapses if you're doing something 12 times a minute? How many seconds elapse? 5, yeah, it's 5 seconds. So think about that. 1 Mississippi, 2 Mississippi, 3 Mississippi, 4 Mississippi, breathe. 1 Mississippi, 2 Mississippi, 3 Mississippi, 4 Mississippi, 5 Mississippi, breathe. 1 Mississippi, 2. Have you ever seen somebody bag vent that slowly in a code? Never. Okay? You will kill the patient breathing that fast for more than the first minute or two. You will alter their pH so much that they cannot recover from it. You got to keep a reasonable respiratory rate. And if you're running the code and you see someone doing that, you got to, yo, slow down. Not a race. Okay? The most you should ever be bagging is 30 a minute. Okay? That's 1 every 2 seconds. That's like 45. Way slow. All right? All right. High performance CPR, yeah. Post-cardiac arrest care. A lot of times we put these people into the cath lab if they're awake, conscious, and have a STEMI, or we cool them if they're still comatose, okay? Hypothermia seemed like it was a really, really big deal. Subsequent studies have not showed benefit as good as the initial studies did, but still there are many, many miracles that we see as a result of hypothermia. What it seems to do for most people is it stratifies them, okay? So before there are 4 grades of injury after cardiac arrest, okay? 4 grades of brain injury. 1 is like I'm fine, 4 is I'm a vegetable, and 2 and 3 is I'm varying degrees of screwed up, right? So what hypothermia seems to do is it takes the grade 2 and the grade 3 and it pushes them to grade 4 and grade 1. So you'll have more people die with hypothermia, but those are the people that would have been severely disabled anyway. And you have more people with great brain recovery. Those are the people who would have been mildly disabled, you know, on a permanent basis anyway. So if I have a cardiac arrest, please give me hypothermia. I would much rather be dead than grade 3 disabled. But that's sort of where the controversy comes, is that this isn't looking quite as great as it originally did. When not to start CPR. This is really simple, actually. If the patient is dead, like irreversibly all the organs are already liquid dead, don't perform CPR. How can you tell if a patient is dead? Well, if they're missing their head, your chance of successful resuscitation, very low. If the patient is in more than one piece, very unlikely that your CPR is going to be successful. If the patient has already decomposed and rats are eating them, I don't even know why they need to put this on here, guys. I mean, you know, if the patient is clearly dead, don't bother with CPR, okay? Move on, find somebody that you can actually save. All right, very good. When to stop CPR. Here's the real answer to this question. Never in less than 15 minutes unless there's someone else that you can save who you're ignoring by taking care of this person you probably can't, okay? After 11 minutes of CPR without return of spontaneous circulation, brain injury is almost universally irreversible. People with metastatic cancer and end-stage renal disease on dialysis almost never make a meaningful recovery to hospital discharge with their brain function intact. Note all the conditions that I attach to that, but the point is, if you're not going to make it to hospital discharge with brain function intact, most of us wouldn't want to be alive, okay? And here's the real answer. When it's clear that you've never made any forward progress in the code, and most importantly, you've asked everybody else who's helping you, okay? Never, ever put someone in a position where they feel like they could have done more to save this person. I've run hundreds of codes, okay? They almost always make it through the code. They don't always make it through the hospital stay. In fact, most of the time they don't, okay? But they almost always make it through the code. If you do the code really, really well, they will almost always make it through the code. But when you're going to call it, you got to look at everybody else who's doing it with you and say, we've been in this code for 22 minutes. We've had no return of spontaneous circulation. Is there anybody here who objects to termination of the code? Anybody at all? Anybody says yes, you go another 5 minutes, okay? Don't traumatize the people that are helping you run the code over the death of someone who's already left this planet. Does that make sense? All right? A few more minutes of tricep workout to help someone sleep at night is a fair trade. Okay. Implantable pacemakers, I do these. You'll usually find them here, but honestly, that's on its way out. The pacemakers that we have now, the brand new ones, they go in through your leg. They're the size of a .22 bullet, and I inject it directly into your heart. They are magnificent. So you'll see no pacemaker wound with those. There's no evidence externally that a patient has one. What you'll see is a thing that looks like a little bullet in the tip of their heart. We're going to skip this. You don't need to know this. George, they don't need to know pacemaker interpretation, do they?
They might need to identify it on us.
Here's how you identify pacemakers. See the spike right there? See the spike right there? Those spikes are not real. Okay, well, actually that spike is, but this spike is not real. The computer put it in there. Okay, the computer is looking for electrical signals that are of a duration and an amplitude that are likely to be from a pacemaker. And if it sees one, it's just going to make a big slash for you so that you can identify it. If it's really, really big, like as big as the QRS, that's real. And it comes from what's called a unipolar pacemaker. But if you see these like weird little spiky things, that may just be artifact if it's a really noisy EKG, okay? So anyway, you see big spikes, look for it to be consistent. You see how these spikes are in front of every single QRS? It's not like just on this one. If you see those spikes on every QRS that looks the same as the one with the spike, it's paced. Is that fair? All right, we're going to keep moving. Oh, actually, this is a really good example. So I said in every one that looks the same. So like, let's say I see this spike right here, and I note this thing's like big and tall and pointy, right? Well, it's not fair to compare that to this guy. This guy's obviously not that guy, right? But I can look at this guy, this guy, this guy, and this guy, and oh yeah, I do see that spike in every single one. It must be paced, right? Okay, good. Pacemaker malfunctions, leave that to me to diagnose. Okay, if you think there's a problem with a pacemaker, don't try to diagnose it in the ambulance. Here's what you need to know for ambulance crews. Pacemakers and defibrillators behave differently to magnets. You guys have magnets in your rigs? Anybody know?
We should.
Okay, if you have a donut and you put it on a pacemaker, what it'll do is cause the pacemaker to pace blindly. It'll just force pacing right then and there. Boop, 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 at a rate fairly close to 100 beats a minute, okay? If you have a defibrillator, what it will do is turn off all the defibrillator therapies. Okay, you put that magnet on the defibrillator will stop shocking even if your patient is dying right in front of you. Okay, so if you have a patient who's going to expire anyway and the wife's like, no, 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 please stop, stop, let him go, and he's still getting popped by his defibrillator, you can put a magnet over it so that the defibrillator will just let him go. Okay? Or, if nothing's wrong with the guy, he's sitting in the back of your ambulance going, oh God, please make it stop! And his defibrillator keeps shocking him. He's getting inappropriate shocks, right? Put the magnet on there, it'll stop doing that. Okay? Okay. Very good. That is it. Gentlemen, you have had amazing endurance. Thank you for putting up with me for this long. I appreciate your time, and I wish you the best on your exam. Please remember my words of admonition. If you fail, it will not be for lack of support. All of your key faculty, all of your SOCM faculty will make the time to teach you what you need to know. If you have questions, look it up, Google it, and if that all fails, come talk to us if the explanations don't make sense, and then we will Google it. All right? Very good.